All right, so Unit 10, cellular regulation. We're going to talk about cancer, how we treat it, and then end of life. So cellular regulation and statistics. Cancer will occur in about 1 of every 3 people currently living in North America. Our risk factors are different for each person. More than 13 million Americans with a history of cancer are alive today. At least 30% of cancer diagnosed in North America is related to tobacco use. It is estimated that 1.7 million new cancer cases are diagnosed in 2019. Cancer-related conditions are the second leading cause of death in the United States. So, we see that the United States has a big problem with cancer, and that could be directly linked to our lifestyle and our diet. So, cellular regulation, how our cells grow or adapt or mutate. Ultimately, as a child, we don't want them to mutate. We need to have continued orderly growth of those cells in our tissues to fully develop and mature. In adults, we'll see more of our dead cells being replaced and hopefully regenerated, any kind of damaged or worn out cells. So like take the red blood cell for example. The red blood cell is supposed to live for 120 days. And it starts to become geriatric around day 90, let's say. So it's not doing a good job anymore. It's really slow. It's not transporting enough oxygen. It's not doing its job. So our body's going to take that red blood cell, get rid of it, send it to the graveyard to recycle some of the iron, but also break down the hemoglobin. And then we get all these new red blood cells coming in. So continued growth is us replacing our dead, damaged, or old cells, and then hopefully continuing to make good ones. Now, if we get a virus or if we get any kind of oxidative stress to our body, those cells can mutate and not be effective or be hyper effective. Either way, it's not good. Cellular regulation is the genetic and physiologic process that controls cellular growth, replication, differentiation, and function to maintain homeostasis. So we need to make sure that physiologically we're healthy, we're not exposing ourselves to anything that's yucky, and that unfortunately there's something that we can't change, but our genetics. Now, if we keep ourselves healthy, our genetic mutations may never kick in. But if we get severe illnesses, if we get like viruses, or if we get bacterial infections, or we subject ourselves to a lot of stress, then those genetic mutations can occur, and then the growth of the cell, the replication of the cell, any part of that cellular makeup is going to change and mutate and not be necessarily good. So what is cancer? New or continued growth not needed for normal development, a replacement of dead and damaged tissues called neoplasia. The neoplastic cells develop from parent cells and have undergone genetic mutations which have led to lack of normal function. If this cell growth causes no harm, it is called benign. But if it is harmful, it's malignant. So if we see here, we have malignant transformations up in this picture up here. And honestly, if you look too close at it, you can see it. There's cells that are different shaped. Some are bigger, some are smaller. There's no rhyme or reason for them. And then you add some vasculature in there, and then gives those malignant cells lots of nutrients to grow. And as you see, it's going to continue to grow. And then sometimes it can get into that vessel and travel along the bloodstream. So when we talk about metastasis, our cancerous cells will metastasize, especially if they're around lymph fluid or blood vessels. That's like a highway for those tumors or those cancerous cells. So primary and secondary tumors, and then knowing, grading, and staging. Primary tumors are identified by the tissue from which it arose, or the parent tissue. So if we look at this picture right here, the primary cancer is in the bowel. There's lots of lymph tissue surrounding your intestines. Let's say when some of those cells break free and go through the lymph system, then all of a sudden you've got the intestinal or colorectal cancer up in your liver, and that's called secondary or metastasis. Cancer cells remove from the original site and then they grow in other areas of the body. Grading and staging is very, very important for our cancer patients, because how do we know that the treatment is appropriate? How do we know what treatment to do? How do we know that it's working or not working, really? So your grades go up to 4. In your staging, we can do all kinds of staging, but really it's looking, where is it? Is it staying in the primary tissue? Has it traveled by lymph node? Is it in the lymph nodes? Is it like a lymphoma? Or has it metastasized to other areas of the body? Cellular regulation and our risk factors. Are risk factors for cancer. So the leading cause of cancer in the United States, or 30% of all cancer in the United States, is from tobacco use or smoking. So that is the single most preventable source of cancer. It's chemical, it is harsh to our body, it causes mutations in our cell, ultimately leading from one kind of cell, and our body changes it to another kind of cell to kind of adapt to that carcinogen. But it is not a good adaptation over time, because that cell that your body replaces it with is not a cell that's supposed to be in your lung tissue. So development of cancer takes years to develop, depending on the tumor and the factors. So is your patient exposing themselves to carcinogens? Do they have a genetic predisposition? How's their immune system? Do they have HIV? If they have HIV, they're going to be a higher risk for cancer. And the one key thing that occurs with everybody, if they make it to 65, after 65, you're at a higher risk for cancer, period, no matter what kind. Physical risk factors would be your UV light, so radiation from your sun, living in Florida. Viruses, I put a nice little table over here to tell you about the viruses and the cancer that they may cause. Epstein-Barr is one of the biggest ones that we worry about with cancer. Epstein-Barr is like a herpes virus, so it lays in dormant. A lot of kids have it when they're younger and have no idea that they have it. We call it the kissing disease, or mono, and it lays dormant in your body. And over time, it has the potential to cause cancer. So we worry about that one, especially with your lymphomas. Dietary, so our diet plays a significant role. Like I said, your lifestyle, your diet, and also your culture. So diet, eating a lot of red meat, animal fats, and nitrates. That puts you at a high risk for cancer. Alcohol should be limited to 2 drinks a day. And then make sure that your patient is eating more bran or more fiber with their fluids, and a lot more vegetables that are high in fiber, including vegetables and fruits that have vitamin A and vitamin C. And then, of course, there is that genetic component that puts you at a higher risk. So if like mom and grandma have the BRCA1 mutation, you could potentially have that BRCA1 mutation. So cellular regulation, our risk factors, and our genetic risk. The acronym that kind of helps us understand our warning signs. So change in bowel or bladder habit, a sore that does not heal, unusual bleeding or discharge, thickening or lump in the breast or elsewhere, indigestion or difficulty swallowing, obvious change in a wart or a mole, nagging cough or hoarseness. And like I say, I always say, if you have a patient that is saying, I've lost a lot of weight and I have not been trying, that is concerning, very concerning. We think cancer. You should think cancer. So primary prevention. When we talk about prevention, we have primary, secondary, and tertiary. Primary is how we prevent how do we make ourselves happy? How do we prevent any kind of risk, really? And then secondary is secondary for screening. If we have hypertension, making sure that we're going to the doctor and getting screened to make sure that it hasn't progressed, it's being managed, and we're not at risk for like a heart attack or a stroke. And then tertiary is always you had the disease, you didn't do your screening, so now your patient with hypertension had a stroke and now they need rehab. So looking at our primary prevention for cancer, avoiding of all carcinogens, so protecting your skin, don't smoke, limit your alcohol intake, don't eat the red meat with the nitrates or the animal fats. Modifying associated factors, so healthy lifestyle, regular physical exercise, maintaining a healthy weight, removal of at-risk tissues. So if you know that you carry the BRCA1 mutation, you can go ahead and get a mastectomy and just get rid of all that tissue so it doesn't even have the opportunity to mutate later on. And then chemo prevention, use of drugs, chemicals, natural nutrients, or other substances to disrupt one or more steps important to cancer development. So these agents may be able to reverse existing gene damage or halt the progression of transformation process. The use of tamoxifen to reduce the risk of breast cancer is an example. And of course, primary prevention is your vaccines. So an example of prevention of cancer through vaccine would be your Gardasil for your HPV leading to cervical cancer. Secondary prevention, remember screening. So regular screening, looking for fecal occult blood annually for adults in all ages, yearly mammograms for women older than 40, clinical breast exam for women 20 to 39 in every 3 years, and then annually for women older than 40 getting a clinical breast exam, a pap test performed at least every 3 years between age 21 to 29 and 30 to 65. Women 30 to 65 will get every 5 years. A colonoscopy at age 50 and then every 10 years thereafter. And then a digital rectal exam for men older than 40. Men older than 50. Make sure you're getting your genetic screening if there has been a high risk for cancer in your family. Now, types of cancer are breast cancer. So if we look at the tissues on this breast, we see some dimpling, we see the inverted nipple, some dimpling. And then on this, we see that orange peel-like appearance on the nipple. I always also say if the nipple has discharge, you're not pregnant or breastfeeding, and if it's bloody, that's a high-risk issue as well. So breast cancer, second only to lung cancer for cause of death in females. Our risk factors, of course, are being female, being older than 65, and those males that are older than 65 are also at risk. Genetic would be an issue if mom or grandma or aunt, whoever has the BRCA1, BRCA2 mutation. Jewish heritage, increased alcohol consumption, childless women or those that bear their first child after age 30, and obesity. So early detection is key. If you know anyone in your family has the BRCA mutations, you need to go get checked, get your lab results done. Your book doesn't really talk about it, but I'd like to talk about it. Your BRCA mutation, your BRCA gene going into mutation does not only put you at risk for breast cancer, but it puts the patient at risk for ovarian cancer. And ovarian cancer is one of the most deadly cancers for women. Clinical breast exam, make sure your patients that are 20 to 39 have their clinical breast exam every 3 years. And then women over 40 are going to get mammograms. Psychosocial assessment, make sure that you're being therapeutic. It is losing a part of their womanhood. Some women do not accept it really well, so make sure that you're being mindful, giving them support groups. And then treatment, you can do biopsy, a lumpectomy, or a mastectomy. Things that we worry about after a mastectomy is no blood pressures or IV sticks. Nothing really should be done medically in the arm that the patient had a mastectomy of the lumpectomy. The lymph nodes are gone. They're no longer there to fight off the infection. You can also see lymphedema occur, and if we look at this picture, this is lymphedema. Once it gets to that stage, it's really hard for it to reverse. Cervical cancer. Most cases of cervical cancer are caused by HPV or warts, genital warts. Health promotion and maintenance, that would be your primary prevention, Gardasil. We recommend that Pap test every 3 years for our patients 21 to 29, and then every 5 years with a HPV test with our women 30 to 65. So clinical manifestations of cervical cancer are typically asymptomatic. You can't see the cervix, so you don't know what's going on there. That's why you have to go get your testing done. If it metastasizes or starts to grow, that's when you're going to start to see symptoms, and that's going to be related to like heavy menses or bleeding after intercourse. Prostate cancer is the second most common type of cancer in men. Men older than 65 have the greatest risk. It is slow growing. Metastasis is a predictable pattern. First symptom is related to bladder obstruction. So if we look here, this is our prostate, this is our bladder, this is urethra. As the tumors grow, it's going to push in on that urethra, and the urine that's sitting in the bladder is not going to be able to come out. So you're also going to see not only the obstruction, but bladder infections, urinary retention, maybe some hematuria. Health promotion, making sure that you're just following those preventative measures for cancer, like a healthy diet, healthy weight, decreasing animal fats, dairy products, eating more fish, eating more fresh fruits and vegetables. And then your male over the age of 50 needs that digital rectal exam. Laboratory, so your PSA. Your PSA is not going to tell you that, yes, that is cancer. It's going to tell you, yes, there's something wrong. So you have to dig a little deeper to find out what's wrong. So your PSA is a screening tool that detects prostate issues. It does not specify if it is cancer. It just says, hey, there's a problem here. We want to keep the PSA, and when the PSA hits number 4, it means bad. I also want to address that African American men are more likely to develop prostate cancer, so their screening should start earlier. Begin prostate cancer screening at age 40 and do early interventions with them. Testicular cancer, this is very important. So with women, we should be doing our breast exams ourselves monthly. Your book says it's not really going to be helpful, but we still encourage it in primary care, making sure that you're also getting the clinical breast exam. So just like the breast exam, the testicular exam, the male should be doing at least monthly, looking for any kind of lumps or soreness or anything abnormal. Higher occurrence in males who have had undistended testes, that's called your cryptochytism, or have an HIV infection. First common sign is a painless, hard swelling or enlargement of the testicle. As it progresses, that male client is going to have heaviness or aching in the lower abdomen or scrotum, and you could be worried about metastasis. Make sure psychological assessments being done. Your book says that it is typical onset like late 20s, early 30s. However, I have seen males come in their late teens with testicular cancer. Those patients are typically more so it's related to the undescended testes. Remember, they have that body image that they're fearful of losing their testicle. So we can offer them a silicone prosthetic, and we can offer them sperm banking. We don't pay for it, the patient has to pay for it, but it allows them to be able to have no problems later when they want to have children. So there are some options to help with dealing of that process. Now, well, going back to the prostate, just make sure that if the patient does have cancer in their prostate, that they are aware that they don't need their prostate to live. The prostate can be removed, and that's when we get into like the TURP, transurethral, that catheter, and we're making, because the prostate is highly vasculature, and we're monitoring for bleeding. You guys should have learned that in MedSurg 170. Then colorectal cancer, third most common cause of cancer death in the United States. It is highly curable. Again, the United States, our diet is awful. It's full of GMOs. It's full of sugar. Not enough fiber, not enough fluid. Now you add into bacteria and genetic risk, then you're a high risk. So first degree relative with colon cancer increases the risk 3 to 4 times. And having a bacteria, H. pylori, strep, or HPV also increases the risk. Most common signs is bleeding. So if your stool has blood in it, it's bad. You should be getting tested for or screened for cancer. If there is inconsistency with your bowel movements, if they change constantly, if the shape is different, if the color is different. Prevention is making sure that you're getting that occult blood annually for all ages, a colonoscopy every 10 years for those 50 and older, and genetic testing. Modify your diet. That's the primary prevention. Decrease fat, refined carbs, and low fiber. So increase your fiber, increase your fruits and vegetables, avoid smoking, limit alcohol, and increase your exercise. And then your head and neck cancer. So your warning signs, mucosal erythroplasia, and the earliest sign of oral carcinoma. So erythro, that's your red, and plasia is just distorted cellular makeup really of their mouth. You're going to see lots of oral bleeding, abnormal color changes. It'll be red, it'll be edematous, you'll have some erosion in some areas, lesions that aren't healing, especially within that 2-week period, lump in the mouth, throat, or neck, having problems swallowing, changes that cause dentures not to fit the mouth, and that does not include weight loss. So if they've lost weight intentionally, their dentures aren't going to fit. This is maybe their dentures aren't fitting because they're swollen, or they've lost an absorbent amount of weight without even trying. Unilateral ear pain and having a hoarse voice. So post-op care for your patient that undergoes any type of cancer removal or surgery to remove parts of the dead tissue in the head and neck area, you're going to assess hourly. You're going to assess that patient hourly for their airway, breathing, circulation. Recognize cues for carotid artery leak. So if you suspect a carotid artery leak, do not touch the area. You're going to call a rapid response. Any additional pressure is going to cause a rupture, so do not touch it. Then your skin cancer. We live in Florida. We know skin cancer is prominent. It's a prominent part of our lives down here. Making sure that we're getting screened, monitoring, doing our own skin checks. But the dermatologist is your friend in Florida, I promise. Because they're going to do skin checks in areas that you can't see, and hopefully find things before it becomes a problem. So overexposure to sunlight is a major cause. Having fair or light complexion, blue eyes, I think is blue eyes, red hair, puts you at a high risk. Prevention of skin cancer, you're going to avoid the sun, especially during midday. Avoid tanning beds. Use sunscreen. Wear a hat. Wear clothing that covers you, sunglasses, examine your body monthly for any kind of lesions, especially lesions that are not healing. Body map your skin spots and make sure that you're monitoring for any kind of changes. So if the mole that you think is just a regular old mole starts to grow, but it is not symmetrical and the borders do not have like clean edges, that's worrisome. Take pictures, make sure you're comparing. Contact your doctor if you find change of color, change of size, the shape has changed, like a sharp border becoming irregular, or a flat mole becoming raised, redness or hyperpigmentation, any kind of tenderness, or oozing crustiness. So types of cancer that we see are actinic keratosis, which turns into cancer ultimately, squamous cell carcinoma, basal cell carcinoma, and then melanoma. Lung cancer is a leading cause of cancer deaths worldwide. It has a 5-year survival rate at 16%. Prognosis is poor, especially for stage 3 and 4. Cigarette smoking is the primary risk factor. So 85% of all lung cancer death is related to smoking. Primary prevention, stop smoking. Warning signs, change in voice, having a cough, coughing up red colored or rust colored purulent sputum, chest pain, tightness, shoulder or arm pain, clubbing of the fingers. Of course, you see that with smokers long term. How we treat it: chemo, radiation, and surgery. Greatest risk factor is tobacco use. Now, we've come a long way, thank goodness. We do scans on patients that have been smokers for, I think, greater than 10 years. You can go get an annual body scan done to make sure that you don't have cancer, because lung cancer is hard to catch. We kind of play it off as, oh, it's just asthma, or oh, it's just upper respiratory infection, and really it could be like a fibroid, who knows, but it's harder to detect. Now, our cancer treatments, so we have chemo, radiation, and targeted cell treatment. Chemo is used alone or in combo therapy. All chemo drugs destroy chemo cells by interfering with DNA synthesis, which disrupts cellular division and impairs cellular regulation. The purpose of chemo is to destroy all cancer cells. We can do chemo intermittently, or we can do chemo with a combo. Intermittently allows those normal cells to recover, where combination chemo increases efficacy, but also increases those side effects. So efficacy means it just increases the likelihood that it's going to do its job, but you're going to see a lot more side effects. You'll see increased cellular death, and it's not going to be just cancer cells, it's going to be all the cells. And then it'll be less drug resistant. So it'll kill off the cancer is what that means. Cancer treatment, so your chemo, you have anti-neoplastic agents, affects all cells in the body. When we're doing chemo, we're going to be looking for NADAR, which is the bone marrow activity and white blood cell counts at their lowest level. We say when the patient gets an absolute neutrophil count, your ANC of 0, they've hit NADAR. To reduce immunosuppression, combination therapy with drugs that do not affect NADAR simultaneously may be used. Chemotherapy, or combo chemotherapy. Tumors with rapid growth are more sensitive to chemo drugs. Extravasation is a serious complication of IV infusion chemo. We don't see a lot of peripheral IV infusions of chemo just because of the toxicity of the drug. It'll kill off the tissue surrounding it, but it can occur. Careful handling. PO drugs are just as toxic to person taking the drug and the person handling the drug as standard chemo drugs. Chemo used with surgery or radiation as adjuvant therapy. So you can use chemo plus surgery plus radiation, and those all kind of help all together, so that you don't use just chemo or just radiation. You can use all the treatments. So chemo side effects. You can get chemo-induced nausea, vomiting, mucositis, peripheral neuropathy, myelosuppression, alopecia, cognitive changes, and altered bowel elimination. And all of these are dependent on how long treatment is and how much of treatment you're getting. So just be aware, cancer's bad, but chemo is toxic. We worry about extravasation. Long therapies, they were going to take the patient hours. When they go into the infusion center, they're going to need a couple days off work because they're going to get sick normally. It takes hours for the infusion, hours to monitor after. So the therapy is not a one and done. It takes months of this. Compliance with dosing and schedule is necessary. Elimination of all bloody fluids with all traces of chemo for up to 48 hours. So your body fluids are going to be toxic if you've had chemo within that 48-hour time period. Toxicity. Chemotherapy is not selective and kills all cells. This toxicity is normal cells can lead to dose reduction because of risk of fatality. This is the reason we give chemo in rounds and cycles, and then allow the body to rest, and then we do another round or cycle, and then we allow the body to rest, because we do not want to kill the patient. Cancer is already trying to do that. We're trying to kill the cancer that's in the patient. Extravasation. Many chemo drugs are viscous or irritating. Viscants cause tissue damage on direct contact. Irritants can cause pain at the injection site along with symptoms of inflammation. Many clients receiving chemo have central lines, but extravasation can still happen with these access devices. The most important nursing intervention for extravasation is prevention. Blood return in the insertion site must be monitored frequently during infusion to prevent this potentially serious complication. So chemo-induced nausea, vomiting. There are different types. So you have the anticipatory, I think that's more of like your nerves, acute within 24 hours of chemo, delayed like the day after, and then breakthrough intermittently. And you have a combo of all of them. Treatment for your nausea, vomiting would be like Zofran, your serotonin antagonist. You can also see corticosteroids, benzos. I've also seen antipsychotics being used. Nausea, vomiting, chemo-induced, can lead to dose reduction due to the client's inability to take enough calories, nutrients, and hydration. So maintaining their nausea, vomiting, because they're not going to want to eat anyway, but now you got them throwing up, and maybe they've got stomatitis happening in their mouth. They're at a higher risk. So making sure you're maintaining the nausea, vomiting with maybe a Zofran or a benzo. Chemo-induced mucositis or stomatitis is another term for it. Dose-limiting side effect of cancer therapy. So high doses of chemo for long periods of time is going to increase your occurrence of these open ulcers in the mouth. Develops in the GI tract. Remember, anything from your mouth all the way down to your anus, that whole tube, so your esophagus, your stomach, your intestines, your rectum, that's your entire GI tract. So you could have ulcers anywhere in that tract, but mainly you're going to see it in your mouth. It's going to cause pain, swallowing difficulty, and may lead to an infection. You got lots of yucky bacteria in your mouth. You also have normal flora. When you kill off all the cells, that normal flora overgrow, and you can end up with a fungal infection. And a systemic fungal infection is bad news. So some key things to remember about your mucositis is examining the mouth. If sores or drainage are present, make sure you're calling the doc. Brush the teeth and tongue with a soft bristle brush uh, at least every 8 hours and after meals. Avoid the use of mouthwashes that have alcohol, so like Listerine. Swish and spit room temperature tap water, normal saline or salt, and soda water on a regular basis to keep the area clean. Drink 2 or more liters of water a day. Take all drugs, including antibiotics and drugs for nausea, vomiting, as prescribed. Use a topical oral analgesic. Apply water-based moisturizer to the lips. Use artificial saliva or mouth moisturizers. Lubricate the mouth as much as possible. Don't smoke or drink. Don't eat spicy food. Ugh, I can't even picture having an ulcer and eating spicy food. Use caution when drinking and eating hot foods to prevent further breakdown. If you wear dentures, keep them clean and make sure they fit. Peripheral neuropathy, dose-limiting side effects of cancer therapy, damage related to dose. So basically what's happening is your patient is taking this chemo. It's damaging all the cells, and that does not include that includes your neurons. So it's going to degenerate those neurons to where you get neuropathy. It is a long-term issue. It can be permanent. There's no prevention. So make sure you're monitoring them for falls, physical mobility, constipation, pain, just like your typical neuropathy patient. Lifespan considerations for chemo. Chemo should not be given to pregnant or breastfeeding women. It can cause birth defects. Older adults, we worry about myelosuppression, so the suppressing all of the blood cells in the bone marrow, red, white platelets. Dehydration occurs faster in your elderly. Antiemetic education is very important. We also worry about constipation when we're giving Zofran. Do not forget about that. If nausea and vomiting does not resolve within 12 hours, contact the doctor. So, administering chemo. PPE must be worn when given any types of chemo agent, and that can include PO, IM, intracavity, intrathecal. No matter how the chemo is given, you need to have these precautions in place. So only certified chemo administration or chemo nurse may give chemo. So that includes somebody that has passed their oncology certification. They have knowledge of the meds, the diagnosis, the side effects, the schedule, and the precautions. And it is important to note that only certified pharmacologists or pharmacists, pharmacists can prepare chemo. Chemo use in non-cancer patients. We do use chemo in non-cancer patients. We call them immunomodulators. So like your Crohn's disease, your lupus, your rheumatoid arthritis, any of those immunosuppressant drugs that we give them are really just chemo. So think of like ulcerative colitis, your patient that's getting Humira, or your patient that has, I don't know, some kind of an autoimmune disease and they're getting methotrexate. Their autoimmune system is, because it's hyperactive, if we suppress it, that immune system comes back down to normal and stops killing healthy tissue. Targeted therapy. So how does targeted therapy work? It's a combination of genetic and immunotherapy. We use molecular features in some cancer cells as specific targets. Thus, it minimizes impact on normal cells. It interferes with specific cellular growth pathways or substances involved in cellular regulation. These targeted therapies inhibitors will not work unless the cancer cell overexpresses the target substance. So when we look at targeted therapies, the biggest thing that I think of is of course, your tyrosine kinase inhibitors. That's your immunomodulator. Growth factor, stopping the growth of the cancerous cells. But the big one is your monoclonal antibodies. So that is taking an antigen or injecting like a mouse with an antigen that we're concerned about, a virus, a bacteria, whatever you have. And then that mouse, or could even be a horse, is going to build antibodies. We take those antibodies out of that animal, and then we put it in the patient's body, and it's supposed to attack the specific cells. It can be dangerous. We use these during COVID, monoclonal antibodies, to help people get better quicker, giving them extra boost of antibodies from the people that already are manufactured from other animals or species. So just make sure this is something that you can do and it works, but there is a chance because you're taking something from another species and putting it into a human body that you're monitoring them for side effects. To feed off of that, biologic response modifiers, so your interleukins, your interferons, and your colony stimulating factors. So think your cytokines. If we involve our own immune system and boost it up to, or kind of like make it focus on specific cells, then of course, it's going to stop the replication of that cancerous cell. So interleukins boost immunity. They enhance attacks on cancer cells with our macrophages and our natural killer cells. Interferons slow tumor cell division, stimulate growth of our natural killer cells. And then our colony stimulating factors, our hematopoietic growth factors, they stimulate the production of like blood cells, really, in the bone marrow. Hormone manipulation therapy, so side effects. If any of our hormones are ever out of whack, it puts us at risk for cancer, unfortunately. So, like if we give a woman estrogen because she's menopausal, that could increase her risk for breast cancer by taking that estrogen. But if she doesn't have estrogen at all, that also increases her risk of like endometrial cancer or what have you. So just know if you're putting hormones into your patient, you're manipulating them, and it's going to have side effects. So making a woman more masculine, if we're treating menopause with testosterone, feminizing men, so gynecomastia. Increase of estrogen can cause thromboembolism. Increase of testosterone is going to cause acne. You can see hypercalcemia because if your estrogen is really low, you got hypocalcemia, liver dysfunction, and bone loss. Radiation therapy, the goal is to control the tumor size and spread with minimum damage to the nearby healthy tissue. So reduction in tumor size, we can see it used in palliative care. If that tumor is pushing on something and it's hurting them, we could reduce the tumor size and make it less painful. Relieve obstruction and reduce chance of metastasis if we catch it early. So use of radiation, how it works. There are two ways. We can do it externally or we can do it internally. Externally is where, if we look at the next slide, you can see up here, they're in this big, it looks kind of like an MRI machine in a way, but honestly it has this beam that comes down and burns the tumor really from the inside out. Where internal radiation, you can have a sealed or unsealed internal radiation. Sealed means that it's like a seed. You could swallow it in a capsule, or they can open up the area and implant it into that specific site. This means that the patient is going to be radioactive, but their body fluids are not going to be radioactive. Unsealed, that is more of a fluid, and you're putting it in, and you're pretty much The fluid's going to go in and it must come out, so your fluids are also going to be radioactive. So we see here with seeding or sealed, maybe they swallowed it, capsule, what have you, it was implanted, who knows. You can see they open up the scalp and these are the little seeds, and they put that back on and they close it, and only that area is radioactive. Where if they're getting IV radioactive therapy, what goes in must come out, so all of it is going to be, all the body fluids are going to be radioactive, including the patient. Things to worry about with your radiation is skincare. Make sure that, and protection. So skincare is a big concern, especially if in Florida. So educate on protecting the skin from the sun, going outside early in the morning or later in the evening. Have the patient pat dry after the shower. Do not rigorously rub, and use a clean, soft towel. Of course, no pregnant women, children in patient's room, especially while that patient is receiving rounds of radiation. With sealed radioactive implants, so they got a seed implanted, the RN is to place a portable lead shield between the patient and the door. Limit visitors for 30 minutes, and the visitors must stay 6 feet away from the patient. Nurse to wear a lead apron and never turn their back on the patient. Radiation and chemotherapy can cause myelosuppression, so that's in your bone marrow. It's suppressing all of your myeloid cells, so your red blood cell, your erythrocyte, your megakaryocyte, which is your platelet, and then your myeloid, which is your white blood cells, your granulocytes. So you're going to see a decreased WBC, RBC, and platelet. Remember, nadir is the point in time where the counts of like your absolute neutrophil count, your white blood cell, is at the lowest. It hits 0. Nadir is different. It occurs at different times for each patient with different protocols. So when we get our CBC, which needs to be done daily with our chemo patients, we're looking for anemia, we're looking for leukopenia and neutropenia. So we're making sure that they're on those neutropenic precautions, which is like no fresh flowers, no fresh fruits, limiting visitors, making sure that everyone that goes in and out of the room is hand sanitizing. They're not bringing anything into the room that's dirty. Thrombocytopenia is going to be your bleeding precautions. So looking at the IV site every 4 hours. No enemas. Electric razors only. No Bic razors. Shoes with firm soles. We don't want them to fall. And avoid crunchy hard foods. So quick thing on nadir, where we hit ground zero with our ANC. Clients receiving chemo should understand when their counts will be at their lowest. It is up to the nurse to educate them on what nadir is, when and how to protect themselves, and when to call the doctor. So if they are at 0 white blood cells or 0 neutrophils, they have no immunity. They have no immune system. Granulocytes, remember your granulocytes are your white blood cells, your neutrophils, basophils, eosinophils. So we can stimulate our granulocytes to rapidly produce. So filgrastim, we can give that at least 24 hours after chemo infusion completion. May give daily until neutropenia resolves, and can be given IV or sub-Q. It is very similar to erythropoietin, where we're trying to stimulate the growth of the red blood cell. Filgrastim is for the white blood cell. And pegfilgrastim, give at least 24 hours after chemo, give once per chemo cycle, and give sub-Q with a patch injector. So our oncology emergencies. You're killing off all their blood cells, or all their cells really. There's going to be some emergencies. So the big ones that we look for are sepsis, disseminated intravascular coagulation, syndrome of inappropriate antidiuretic hormone, spinal cord compression, tumor lysis syndrome, superior vena cava syndrome, hypercalcemia. And remember, you want to prevent sometimes you can't prevent it, but you want to catch it as soon as possible because their body can't fight any of this on its own. So sepsis. If we bring back sepsis shock, you guys should know what's happening. If we have a neutropenic patient, they have impaired immunity, it puts them at a high risk for infection. Remember your SIRS alert. Maybe they have a high fever, high respiratory rate, a high white blood cell count, or a low white blood cell count. They have to meet that protocol. But your cancer patients are monitored more severely. Neutropenic precautions. Hand washing or sanitize with alcohol-based sanitizer when touching anything with or on the patient. You're going to monitor the white blood cell count daily. These clients were not going to have typical symptoms that are going to look like sepsis. They could have a low-grade temperature. That's going to be an emergency, so a temp of 100.4, emergency. Mortality rates close to 36% if they go septic. High-dose, broad-spectrum antibiotics are given if possible. Vital signs every 4 hours, and make sure you're drawing your cultures, getting a chest x-ray every 24 hours if fever of 100.4 continues. Now, disseminated intravascular coagulation, often caused by gram-negative sepsis, but can be caused by viral or other bacterial infections. It means that there's extensive abnormal clotting, and then your body gets depleted of those clotting factors, and then you become a bleeding issue. So bleeding then occurs, and it can be oozing or hemorrhaging. Those little clots will still block the vessels and cause ischemia. And we worry about, so you're going to look for pain, dyspnea, tachycardia, bowel necrosis, kidney damage, or stroke-like symptoms. So in early DIC, you're going to make sure that that patient has anticoagulants or heparin to limit clotting and prevent rapid use of circulating clotting factors. So if we limit how much is being used, you're not going to run out of it. If DIC progresses, we give clotting factors. What else is associated with DIC? Leukemia, adenocarcinomas, prostate chemo, release of thrombin or thromboplastin with your blood transfusions. In the treatment, you must catch it early because the mortality rate is up to 70%. Treatment for DIC is to treat the underlying cause, such as cancer or infection, and prevent bleeding. Your SIADH, syndrome of inappropriate antidiuretic hormone. Remember, this is where they aren't peeing. They're fluid overload. You'll see this with small cell lung cancer. Some cancers make and secrete ADH, while others stimulate the posterior pituitary to secrete ADH. Water is reabsorbed by the kidneys, put into systemic circulation. Sodium levels drop because they are severely diluted. Too much fluid, not enough salt. Early signs, so sodium is going to be low, anywhere from 115 to 120. That is a critical number. You're going to see weakness, loss of appetite, muscle cramps, nausea, vomiting, lethargy, edema, confusion. Late signs, when the sodium drops below 115, seizure, coma, death. So what are our interventions? Well, we can give tolvaptan. Tolvaptan is going to help remove the fluid but keep the sodium. We want to get them peeing for fluid restriction, but if we do give fluid, it has to have salt in it. So 3% normal saline to replace the sodium level. Increase sodium intake. Treatment cause could be from chemo. So our priority Interventions are safety, restoring normal fluid balance, monitoring your sodium level, and supportive care. Spinal cord compression. This occurs when a tumor directly enters the spinal cord or column, or when the vertebrae collapse from a bone degradation due to a tumor. Mets from lung, breast, prostate, and colon could also cause spinal cord compression. So when you have any kind of cancer tumor that is metastasizing, most frequent area for spinal cord compression is the thoracic spine. You verify spinal cord compression with an MRI. Treatment should begin immediately if you suspect spinal cord compression to preserve function. First symptom of your spinal cord compression is going to be pain followed by weakness, gait changes, sensation changes, urinary retention, and constipation. Back pain is the first most common symptom. How do we treat it? High dose steroids, high dose radiation, and in a few cases, surgery. You see a lot more steroids being used with this. Treatment is focused on relieving the compression on the spinal cord. And then hypercalcemia. As we know, calcium plays a significant role in your bones, in your blood, in your muscle contractions. So if it is too high, it can be fatal. Things that cause hypercalcemia is multiple myeloma, or when cancer metastasizes, especially bone cancer. Calcium from the bone will then be pushed out into the bloodstream, and then you can't use it for your muscles or your bone, so you're at risk for your bone breaks, which will further increase your calcium level, and your cardiac conduction is no longer going to be working because of the muscle. Early manifestations could be non-specific, so you could have some pain. Remember your stones, groans, bones, thrones, psychiatric overtones, those are going to be early manifestations. So skeletal pain, kidney stones, abdominal discomfort, altered cognition. You can have some fatigue, loss of appetite, constipation, increased urinary output as your body tries to get rid of the calcium. But the serious manifestations where your patient's not going to have any deep tendon reflexes, their muscles are no longer contracting, so they could have a paralytic ileus, dehydration, the shortened QT interval, an ST segment, so our ventricles are not going to be able to relax as well, so we're not going to get good blood flow. Interventions, oral hydration if they can. The whole goal is to get them to pee out the calcium. So we can do IV fluids and a diuretic, but we are never ever to give hydrochlorothiazide, HCTZ, for hypercalcemia. We want them to pee out the calcium. A thiazide diuretic reabsorbs the calcium back into the body. So you can give a loop diuretic is probably the best one. A loop and an IV fluid. Your superior vena cava syndrome. This is compression or obstruction by tumor growth or clots in the vessel. Our symptoms: edema of the face, periorbital edema, head fullness, especially when arising in the morning, engorged blood vessels, erythema of the face. And then your late symptoms, as it continues to swell, if we look at the picture here, as they continue to swell, you're going to have shortness of breath, cyanosis, risk for hemorrhage, altered mental status. You're no longer getting good blood flow to the heart, so it's going to be decreased cardiac output and hypotension. If we look at the compression of the superior vena cava, is up here. So we have lymph nodes. We have a tumor that's also compressing on it. So that means blood can't get into the heart area. So blood is accumulating up into like the neck and the head. So how do we treat it? It's careful monitoring. We can give them steroids and diuretics, ultimately high dose radiation or chemo. We can do a metal stent to kind of open up the area, palliative care, But ultimately, Shapiro-Vinnikova syndrome is late-stage disease, and cancer is probably widespread, so we're going to focus a lot on palliative care. Then tumor lysis syndrome occurs when a large tumor is destroyed by treatment. The rapid destruction of tumor cells releases potassium and uric acid into circulation. Can we handle all of that potassium? All the stuff that's leaking out of those cells is now in our blood, and we cannot, our body can't handle trying to clean up all of that. It's too much all at once. So it's going to lead to electrolyte imbalances and acute renal failure. You're going to see high potassium, high uric acid. So manifestations: lethargy, muscle weakness, nausea, vomiting, diarrhea, cloudy urine, flank pain because the kidneys are overworking. You're going to see cardiac changes, muscle cramps, twitching, so dysrhythmias. Hydration is very important before and after. We want to diurese them, but cautiously. Don't overwork that kidney too much. And allopurinol to help with the uric acid. So prevention of your tumor lysis syndrome: hydrate 24 to 28 hours before chemo. Educate clients to drink at least 3 liters of fluid a day. Make sure it's consistent, not in one sitting. Sodium bicarb to help prevent uric acid precipitation, and allopurinol to reduce uric acid production. If tumor lysis syndrome occurs, meds are given to remove potassium and uric acid from the body. So we can give IV fluids, loop diuretic, insulin, Kayexalate, sodium bicarb. Remember, they're going to be acidotic. Those are the big ones. Your patient is going to need to be in the ICU and on dialysis. So nursing role in cancer care: assess the needs of the oncology client under your care, discuss goals with the family, but family's typically going to want something different than what the patient wants. So make sure you're discussing privately with the patient as well. Create priority nursing diagnosis plan, appropriate interventions, and input from the client and family. Implement priority interventions. Evaluate goals and outcomes. And it is the utmost important for you to evaluate how you feel about what's happening. So, Jerry considerations: 58% of all cancers occur in 65 or older. 2/3 of all cancer deaths occur in those that are 65 or older. Physiologic changes: remember, everything gets slowed down, you start losing stuff. So elasticity is no longer there, skeletal mass, structure and strength are decreased. Immune system is impaired, alterations in neurologic and sensory functions, and drug absorption, or how it's distributed. It stays longer in the body. Performance status is a score that helps to shape cancer treatment based on the client's ability to care for themselves. The scores can predict how well a client will do with their disease process and treatment regimen. Those with a lower score tend to have a difficulty tolerating rigorous cancer treatments. All right, now to our end of life, palliative care. This palliative care is not the same as hospice. Palliative care, a philosophy of care for people with life-threatening diseases, helps clients and families identify outcomes for care, assists them with informed decision-making, helps them with quality symptom management. We could do curative therapies with palliative care, but you cannot do curative therapies with hospice. Care is not dictated by time frames. So if anybody knows Elizabeth Kubler-Ross, she was like the idol for all hospice nurses out there. She was the one that came up with the stages of grief and the death and dying process altogether. So when illness or trauma overwhelms, the compensatory mechanisms of the body and the lungs and heart cease to function. Heart disease is the #1 cause of death in Bexar County, followed by cancer. Some of those, I don't know why Galen has that on there. I don't even know where Bexar County is. Anyway, back to topic. Some of those you care for will eventually die from cancer. You should evaluate how you feel about death in the dying process. If you stop being moved by death, you should get out of nursing. In dying is a process, and through that process, the stage of grief are experienced in cycle. Some people can handle death and some people cannot. If you can't handle death, I highly encourage you to work in an area that doesn't see a lot of death. So like your orthopedic floor, uh, your mom baby typically doesn't see a lot. It's more of a happier area. You do sometimes see it, but it gives you more of a chance to step back and say, I'm not comfortable with this. Where if you're on, I don't know, you work in geriatrics, or you're working spinal cord neurology, or you're working cardiovascular, you're going to see a lot more deaths, and you have to be able to cope with that, because you do get kind of close to some of your patients sometimes, but you also have to be able to step back and say, they are not a part of me. I'm here to do a job. So hospice. It's an interdisciplinary approach. It assesses and addresses holistic needs of clients and families to facilitate quality of life and peaceful death. It can be done at home, in a nursing facility, or as a general inpatient. Is generally when a client has 6 months or less to live, but can be extended on a case-by-case basis, must forego curative treatment for their terminal illness. So the principles of hospice care: death must be accepted. The client's total care is managed by an interdisciplinary team. Pain and other symptoms are managed. The client and the family are viewed as a single unit of care. Bereavement care is provided for family members. So I'm sure you guys all know my passion for hospice. I have worked hospice on and on for about 15 years, on and off. I left hospice in 2023, I believe, just because there is a lot of politics right now with what's happening in the government. So when we look at hospice, when you look at the team, so I was a manager of the team, and I was managing two social workers, a chaplain, multitude of aides. Aides are very important for the hospice care, and a multitude of nurses. Not only that, but the doctors were also on the team with us, and we had nurse practitioners. So that is your interdisciplinary team. Yes, you can consult out to like physical therapy, but the physical therapist is only there to help with comfort. So if they can't, I don't know, find a comfortable way to move to the side, like roll over on the side, instead of the way that they're doing it. That it's not to make them 100% better. It's just to help them find ways to maneuver themselves. So that is your interdisciplinary team. Hospice will manage all symptoms if the patient allows it. They can keep their primary doc and keep taking all of their like blood pressure medicine. They can keep taking all their medicines if they want. The goal of hospice is not to stop them from taking or caring for themselves or not treating appropriately. We still treat for those infections. You still make sure that they're doing like trach cares and ventilator cares and all of that stuff. But the goal is to provide them with care that is going to not prolong their life, because they don't want any more curative treatment. You are there to help treat with the family. So family is part of your patient load. The 6 months process. So in order for a patient to come onto hospice service, a doctor has to say, yes, this patient has 6 months, or I predict this patient has 6 months or less to live. That does not mean that they are going to die at that 6-month mark or before the 6-month mark. They go through a recertification process every 90 days to make sure that we have not inappropriately been billing for funds to care for a patient that is supposed to be dead. We could, I mean, we're not God. We can't predict when someone's going to die. I've had patients that have been on hospice for 3 years. I've discharged patients that are 110 years old. It's just a parameter. Yes, this patient, they're more than likely, they don't look good. The scales that we're using indicate that their prognosis is very poor. They do not have a good quality of life right now, but we're going to try and make them comfortable. That's like the recertification process. And they look at the overall picture. What's their BMI? Have they lost weight? Have they lost a lot of fat tissue? What's their eating like? Are they getting up? Are they moving around? What's their pain like? All of that fun stuff. So, palliative and hospice comparison. Palliative care emphasizes management of psychological, social, and spiritual problems, as well as control pain and other physical symptoms. The goal is to improve quality of life. Where hospice is associated with not only palliative care, but also providing quality of life while approaching the end of life. So, barriers to the end of life. Cure is the focus of healthcare institutions. So nothing will make someone more upset than saying, I want to consult hospice on a med-surg floor. Nobody likes hearing that. Um, so, and we would have consults come in, and as soon as they hear the nurse even outside the door, they're like, we're not doing hospice, you're not welcome here. People get so afraid of hospice. Financial criteria and reimbursement issues. This is why I left hospice the last time, because they are now doing star ratings on hospice care. And if you don't know what that means, I highly encourage you to learn about HCAHPS scores and reimbursement rates. So people are getting payment is based on the person dying's HCAHPS score and their star ratings of all that. Cultural and social issues. So, do they believe in comfort care? You also, barriers to that plays a significant role in what we find as a society as cultural inappropriateness in care, period. Um, just like having like 10 people in the house at all times. I was at a patient's home one time, and they wanted the 10-year-old to give Nana her bath and do the whole Foley care process, where I wouldn't find that appropriate. They were okay with it. So know that there's barriers to care all across healthcare, period. Discomfort with addressing the issues of death. Lots of people are very scared of dying. And hospice has made me pretty spiritual, not necessarily spiritual with religion, but spiritual as the end of life, there are crazy things that can occur, and it really opens your eyes. Psychologic and coping responses to death and dying, such as denial. That's one of the biggest things that you'll see, especially with your families, is the denial, the anger. So you have to be able to communicate appropriately, especially if you're going into their homes. The hospice house is a little bit different, but going into their homes is you are entering their home and you need to be respectful. So planning for end-of-life care, where does the person want to pass? Do they want to pass at home? Do they want to pass at the hospice house? Most of the time, you will hear families say, I don't want them to die in this house. And then they'll be put in the hospital. But the thing is the government only pays for 10 hospice beds, I believe. It's like limited to the amount of beds to the compared to the hospital. It's like a ratio. St. Joe's, Maine has 10 hospice beds for the whole hospital that will be paid for. Are there any advance directives? Those are very important. You normally get those on the day of admission. Is there a medical or durable power of attorney? Also very important. Get that on the day of admission. Is there a living will? Out of hospital DNR, the yellow form. If they don't have the yellow form, you kind of talk to them like, hey, you want us to do CPR and the full shebang in the house, or do you want to die comfortably? It just depends on what they want. But ultimately, you need that yellow form filled out if they do decide that they're going to be a DNR, and that has to go with them everywhere. If they get admitted to the hospital, they have to take that yellow form with them. Many of these conversations have to be performed with a lawyer or a physician. So communication, reflect on your own values and experiences regarding illness and death. Use clear, non-medical language. Be fully present and attentive during communication. So one of the rules that just came out was the at bedside charting for a hospice, and they were actually they put monitors on the nursing and aide phones to make sure that they were bedside charting, because it monitored their location, which has been it took away from being attentive in that vulnerable time when someone is at the end of their life, their family is grieving. So back to our communication. Let clients and family guide the conversation and care priorities. Be an active listener. Make sure that you're listening and not contributing a lot to the story. Let them tell you their story. Allow silence and give time for reflection and response. Minimize distractions. Avoid giving unsolicited advice or scripted responses. I feel like our culture is really heavy on this. I'm so sorry for your loss. Prayers. That's I know how you feel. It'll get better. Better with time. Don't say any of that stuff. Do not give any kind of scripted response. Don't say what you did to get better. Just be an active, open ear. I know that's difficult and it feels weird, but I promise it's better to have that weird feeling than to put your feelings into somebody else. Ask questions and ensure mutual understanding. So spirituality, that includes religion, but it doesn't always mean religion. It is a spiritual assessment. Addressing spirituality is an important component of the dying client. Not only is it, are you Baptist, are you Catholic, are you Seventh-day Adventist? It is, what do you believe? Where do you believe that you will go after you pass away? How do you want to be cared for? Is there anything, would you like a rabbi? Would you like a priest? Would you want just a social worker? Do you want us to pray? Do you not want us to pray? Spirituality encompasses a lot of things. Signs of approaching death. So refusal of foods and fluids. I would say yes. I mean, definitely they're not going to be eating for, just depends really. I've seen patients not eat for 2 weeks and then die like a week later. So ultimately almost a month goes by with no eating. It's the fluids that gets them. And really they could live a couple days without any fluids. But their taste buds are going to start to change as you get older, really. Your taste buds change and you don't want the things that you used to want. I'll never forget one of the first times that I was in a teen conference, a research process, where we talk about all the patients. The physician sat us all down and made us play Bean Boozled, which, if you've never played Bean Boozled, it's an experience. She goes, I want all the staff here to recognize that this is what happens. You think that your patient wants something, like maybe they're Italian and they want that meatball sandwich, but they eat that meatball sandwich and it tastes like dirty socks. That is a normal process, especially if you are no longer doing curative treatment and you have cancer or what have you. Taste buds are going to change and they're only going to like certain things. But as they stop eating altogether and fluids altogether, you can see a decline more rapidly. Urinary output decreases because they're not drinking. Weakness and increased sleep. So this has always been one of the things that always gets us is they'll have like a period of long time of sleep and then they'll have this burst of energy out of nowhere, and then when that happens, as a hospice nurse, we know that it's probably going to end very soon. So they get that rapid burst of energy, everything's fine, and then the next day they could die. Confusion, restlessness, impaired vision and hearing. They could also hallucinate. So we say hallucinate very lightly because we don't really know the afterlife, right? Secretions in the throat. This is what freaks people out the most, especially the family members. We used to give atropine for it, but evidence-based practice, because atropine is an anticholinergic, it dries you out, so it dries out what they call the death rattle. However, when you give atropine, the heart rate speeds up and the patient lives longer, and it's not a good situation to live longer in that scenario. Breathing patterns change, so you're seeing Shane Stokes starts to occur. Incontinence, and you'll start to see the incontinence turn more of red as the time approaches, and then decreased temperature control. Stages of grief. So Elizabeth Kubler-Ross came up with this. And you do not experience these in a simple, systematic order. You're going, and that's why I put this picture is really great. So 5 stages of grief, you see these arrows going all which ways. Just know that they do happen. It's just they're going to happen in all different manners. One day you'll be angry, the next day you're going to be bargaining and crying. So denial, anger, bargaining, depression, and acceptance. Acceptance does not mean that they're over it. It just means that they're coping. So never approach our patients that are feeling like they've accepted it as, oh, I'm glad you're better now. They're just coping. They're finding ways to go day by day right now. These stages are experienced by the person who may have terminal illness and the people who care for that person. Remember that everybody grieves differently. And then the last but not least, care of the body. Be sure to keep in mind religious beliefs. Some people do not want you touching that body. Think about the Jewish. They don't allow that body has to be in the home for 7 days, or can't be buried for 7 days. So make sure that you're aware of what the family wants and how they want to care for it. Some people want you to clean the body with them. Some people want you to do it you to do it on your own. Some people don't want you touching the body. I've had people get really upset because the eyes don't close. And unfortunately, that's a real thing. Your eyes do not close. Your lids kind of stay open. So finding a way to tape them down so that the patient's not looking at their eyeballs. Just make sure that you're mindful of what the family wants. And that is it. I will see you guys in class. Take care.